Well, thank you very much, and good evening, and welcome to the IMF Best of ASH teleconference. Our speaker tonight is Dr. Brian Durie, Chairman of the Board of the IMF. ASH, which is the American Society of Hematology, is the premier meeting of the year, and thousands of people from all over the world attend this key event. ASH is truly the ultimate meeting, where all the latest data and updates in hematology are presented. I think it's wonderful that so many people are listening to the call tonight, as Dr. Durie will be presenting a recap of the most important developments and advances in treating myeloma that were presented at ASH, and this information is truly invaluable. Before I turn it over to Dr. Durie, I'd like to take a moment to thank our sponsors, Amgen, Celgene, Janssen, and Takeda Oncology. It's really wonderful that they support this program, and we greatly appreciate it. As a reminder, March is Myeloma Action Month, so please go to our website, myeloma.org, for more information about that. And one last thing, you can find the link to tonight's slides by going to our website, again, myeloma.org, and just scroll down and you'll see a banner with Dr. Durie's picture on it. It's on the left-hand side of the page. Then just click on Best of ASH 2016 and you'll be all set. So now sit back, relax, and Dr. Durie, it's all yours.
Well, thank you so much, Susie. I'm very pleased to have this opportunity. I picked this title of Myeloma Perspectives 2017 because the idea is to take the information from this important ASH meeting in December 2016 and really translate that into how is it changing our perspective about the diagnosing and treating of myeloma for this coming year. And so on that first slide there, I show a picture of the moon starting to peek over the mountains here in Los Angeles. I think, unfortunately, we won't be seeing the moon quite like that tonight because of the significant clouds and rain, even mudslides that we've been having out here in Los Angeles. But this is an ideal evening in Los Angeles, but perhaps not tonight. So if you go to slide number 2, what I've done with this opening slide is to summarize the key topics that emerged from ASH, but also, more importantly, summarize the areas where there are some important questions and areas where new data help us to think about the treatment or approach to treatment in perhaps slightly different or better ways. And so the first topic, who should be treated? Another way of saying that is really when should treatment be started? And then if you are going to start treatment in 2017, what are the recommended first or frontline options? A key topic continues to be, where we have new data, is should these newly diagnosed patients have an autologous stem cell transplant, an auto transplant as part of their first therapy, or maybe even defer that to later, possibly. And then the fourth item, MRD, minimal residual disease. As has been the case the last couple of years, a lot of abstracts at ASH have been looking at minimal residual disease testing, particularly in the bone marrow, but here more recently also in the blood, to see if that test is positive or negative. Is there minimal residual disease? Is there not? And what does that mean for the approach to the treatment? Can treatment be stopped? Should treatment be changed? Things like that. And then what is frequently very, very important, if the MRD test has been positive, if perhaps relapse has occurred, what do we currently recommend? And then finally, among those recommendations, what are some of the new agents? What are the new options that could be important to be aware of in thinking about the treatment of relapse refractory disease for a patient who's maybe gone through a lot of treatments, 3, 4, even 5 different therapies, and what would be the thing to think about now? And so if we go to the next slide, slide number 3, when should treatment be started? This is what we call an algorithm, one of those like branching trees. And so if you look on the left, you'll see basically what is myeloma. Something that we've talked about quite a bit recently is that myeloma is not just someone who has symptoms, someone who has what we call these CRAB criteria, changes in the calcium, kidney function, anemia, or bone disease, these CRAB features which may cause the patient to be quite symptomatic, to have bone pain, anemia, other issues. Those are patients definitely needing treatment, but we've expanded that to include patients with a little bit earlier disease, those who have what we call myeloma-defining events, MDE, and this could be reflected by a high percentage of plasma cells in the bone marrow. You'll see that listed as greater than 60% PC, so if the bone marrow shows more than 60% plasma cells, if the FLC is greater than 100, this means if the serum free light test, that light chain level measured in the blood using the serum free light test, if the ratio between the abnormal and the normal is greater than 100, and then if, for example, the x-rays have not shown any definite bone lesions, but an MRI shows more than one focal lesion, or what we mean is more than one spot on the MRI where there's a definite area of abnormal myeloma, then those would be sufficient to say that myeloma treatment should be started, so treat as myeloma. But the current situation is that we're looking to even jump in a little bit sooner, and the whole concept here is similar to other kinds of cancer, where if you do have good treatment, and as I'm going to be discussing, we are fortunate to be having better and better treatment options available, then the best thing is to get started as soon as possible if you're clear that there is a need for treatment. And so if you go down the branching tree on the right, you'll see that it says high-risk SMM, which is high-risk smoldering myeloma, and then low-risk smoldering myeloma. High risk is where we have indicators that tell us that certainly within 2 years, maybe within a year to 18 months, active myeloma will emerge. And so what we're really looking for there are very clear indicators that this will definitely happen. And so those maroon boxes are saying this is kind of an evolving area. There are a number of those risk factors, and we're looking more and more closely at those to see if we can have a decisive recommendation. But the idea really is, if we do have that, then we might end up recommending treatment as for myeloma. Whereas over on the right-hand side, we are going to be continuing to monitor patients and maybe significantly delay any intervention, because we certainly want to treat someone who needs it, but not intervene or give treatment to someone who really doesn't. And so if we go to the next slide, this leads to a little bit of a dilemma currently, and I get a lot of questions about that to say, well, okay, if you have high-risk smoldering myeloma, HR, SMM, so this is on slide number 4, how should it be treated? Well, right now we have options that could be considered gentle or maybe not so gentle. And so in the orange box, there have been studies looking at using Revlimid and Dex, or maybe daratumumab alone. This is the anti-CD38 monoclonal antibody, or a recent study, this was presented at ASH, elotuzumab combined with Rev-Dex. This was a well-tolerated regimen, and so obviously seemed to be pretty active for high-risk smoldering. But the thing about those options are that although they might easily control high-risk smoldering myeloma, is that really the best thing to do? Is this in the best interest of the patient? I mean, if you're going to jump in early, shouldn't we be looking to do a more decisive job? And this is really one of the whole ideas of the Black Swan Research Initiative, that if you're going to jump in early, there is this opportunity to hopefully to start to cure myeloma. And so we do have these protocols that are starting. Well, one is started and one is two of them are about to start. The CAESAR trial, which has accrued about 50 patients in Spain already. This is a combination of K, which is Kyprolis or carfilzomib, Revlimid and Dex, plus autologous stem cell transplant. The ASCEND trial, which will be starting very, very shortly in the U.S. and multiple centers, and we'll be sure to keep you alert to this. This is KRD plus daratumumab plus transplant. And then as part of our Iceland project, which I've talked about, I'll be happy to take questions about that, but in the early disease situation, we're going to be using the daratumumab RD, which is actually what's called the Pollux combination, which I'll be talking about tonight. And so we obviously don't know the 100% best answer to this question right now, and actually the standard of care is quite possibly to still observe until you are clear what you might want to do. But we're excited that maybe this early intervention is truly an opportunity to start curing myeloma. So if we go to the next slide, this really summarizes where we are in terms of traditional frontline options for therapy right now. And there were certainly updates at ASH this year. And what we're looking at here in this slide number 5, is largely what was presented at ASH, not in 2016, but 2015, where Velcade, Revlimid, and Dex, which I'll talk about in a moment, emerged as possibly one of the best options in this frontline setting. But if you look here at the frontline options, it's divided up into eligibility for autologous stem cell transplant, ASCT, yes on the left and no on the right. And I think that the bottom line right now is that we feel that using a triple therapy, particularly Velcade, Rev-Dex, or a combination of what we would call a proteasome inhibitor and IMiD and dexamethasone could be your best choice. In the United States, we are fortunate that is a feasible option, and patients in the U.S. can receive VRD, and RD as a doublet could be considered, especially for fragile patients. But mostly we would be thinking VRD or possibly Velcade, Cytoxan Dex, Cybor-D, if VRD was not possible for some reason. Unfortunately, outside of the U.S., where VRD is really not an option in the frontline setting because of the approval and access status, VTD, Velcade, Lenalidomide Dex, would be the frontline therapy, like in France or Italy or Spain, somewhere like that. And they would use VCD as a backup, or maybe Velcade Adriamycin, an older regimen, as a backup. Beyond that, maintenance with lenalidomide or bortezomib would be the option. Over on the non-transplant side, the option in the U.S. would again be very, very similar. So the good news for 2017 is that the options, the preferred options, or the recommended options, have become rather simple. VRD with some dose reductions or schedule reductions to make it VRD light for an older, over age 75 or fragile patient, or perhaps even just the doublet Revlimid and Dex RD for an older patient in the U.S. Outside of the U.S., the combinations with melphalan are still widely used. Velcade, melphalan, prednisone, which is rarely used in the U.S., or melphalan, prednisone, and thalidomide, which is also rarely used in the U.S., with some backup options there. And so relatively simple in the U.S., VRD, RD, maybe the Cybor-D as these frontline steps. Next slide. I thought it would be helpful and appropriate to go through a little bit the details of the SWOG S077 study, which highlights the value of the VRD regimen in the frontline setting, and that's because it was presented at ASH in 2015, and it just in December of this year was just published in Lancet, and so these are data that have just come out for full publication. And so this was a large randomized study, 525 patients, and this is on slide number 6. In the blue, you have bortezomib, lenalidomide Dex, so Velcade, Revlimid and Dex, so VRD. In this case, the Velcade is given intravenously twice a week, and so this is an older regimen. We would tend to use, obviously, subcutaneous injection now, and maybe even 1 day a week to reduce the neuropathy. In the red, you have the RD regimen. This is lenalidomide and Dex using the standard regimen. The comparison was with what were felt to be the traditional schedules. The VRD was given in a 3-week cycle, the RD in a 4-week cycle, 8 cycles of VRD, 6 cycles of RD. This gave 6 months of induction for each regimen, but using a 3 or a 4-week option. If you go to slide number 7, SWOG S077 outcome measures, you'll see very important differences. The patients who received the VRD for the first 6 months, an 82% response rate. It was probably even higher than that. In this cooperative group study, some of the documentation of even partial response was not quite as good as it might have been. So the response rate was possibly even a little bit higher than that, but certainly 10% higher than the RD arm, with about a 10% difference in the deeper responses, very good partial response. This translated into a difference of a year or in excess of a year for both remission, PFS, 46 months versus 30 months, so that we're now talking about a first remission in the 4-year range and a median overall survival in excess of 6 years. So now we have a newly diagnosed patient, and this is including the whole range of patients including over the age of 75, a median overall survival in excess of 6 years. So a very, very important point. And if you go to slide 8, you can see what we call these survival curves, progression-free survival. So this is basically the length of the remission. And this was, as I said, basically a 1-year difference. On this curve here, it's 43 months, basically 30 months, a very important difference. If you go to the next slide, slide number 9, I think that this is a key point in thinking about where are we with the treatment for myeloma right now. So this is the progression-free survival if VGPR was achieved. And so the big thing about the VRD versus RD is that there were more deeper responses. There was more VGPR. And so if you look at the patients with the VGPR, which is in the green, so you'll see the green box, VGPR, and then you see the green curve, you'll see that that is the top curve, and that's because the remission for those green patients, the VGPR patients, was even a little bit longer than 4 years, whereas if you look at patients who had a stable response, it was actually about 1.5 years. And so a huge difference between patients who achieved a VGPR versus those who did not. But it also tells you that the advantage of the triple therapy is because it gives you that deeper response. Next slide. And so if you just look at the survival overall, not considering that VGPR part, if you just look overall, the VRD, which is the red curve on slide number 10, that red curve is higher than the blue curve, which is the Revlimid and Dex, the doublet, and so you can see there that there is about a 1-year difference in survival. And so a reason that people have paid attention to this is that this was a very difficult study. I mean, that 777 number, that means that we were starting to think about that study in 2007, 10 years ago. The study started very early in 2008. And so here we are 10 years later, and finally I can tell you that there is an advantage to taking 6 months of VRD in the first 6 months versus RD. And so This is quite an achievement, actually, to finally have this information, and it's for this reason that if you go to the next slide, slide number 11, the MSMART team, and I would say particularly led by Vincent Rajkumar, he has said, look, this is one of the few studies, actually the only study that has this type of long-term follow-up in the absence of transplant to show that the VRD, which is the red box, really is better and should be selected in both arms of this branching tree. And so that for the transplant candidates on the right and then on the non-transplant on the left, VRD, that red box, should be in there. Now, if you're frail or if you're elderly, and also, I mean, if for some reason the triple therapy is not necessary, it's not as if RD is actually a bad therapy, and quite frankly, we are continuing to look at the subset of patients. There are definitely some patients who can do beautifully with the doublet, and so we're really looking carefully to see in more detail who exactly those patients might be, because that is important. But certainly on average, if you have the ability, that the three-drug regimen VRD would be your choice, and certainly for transplant candidates. And then over on the right, you'll see that underneath the red box, there's a gray box and a blue box. The gray box says that maybe you could do VRD consolidation, maintenance, and then delay the transplant, whereas in the blue box, you might go ahead and do the transplant right away. And so the key question is, should you do that transplant right away? And this is a very important piece of ongoing information that has been updated and was updated a little bit at ASH. And so if we go to the next slide, this shows you what was presented at ASH 2015, and which has been updated, and these data that I'm showing you are now going to be coming out actually in the New England Journal or rather soon with some commentary about this. And so if you look at the VRD, which is the SWOG 777 regimen, and then you look at half of the patients who had ASCT, or what the French call high-dose therapy, HDT. This is an IFM study 2009 on slide number 12. You'll see that the top curve, high-dose therapy, is significantly better than the non-high-dose therapy. So it's pretty clear that the remissions are better with the upfront transplant. And so this was 4 cycles of the VRD, and then they went ahead and had the transplant. And what was also evident is, just like in the SWOG study, there were more deep responses with the transplant, including more VGPR, CR, and all the way down to MRD. What has caused a little bit of a confusion and what one could consider an open question is on the next slide. And so it's quite important to look at the next slide, slide number 13, overall survival, OS. And this shows you that if you look at the survival currently, and this is out a little bit beyond 4 years, so you start to understand that it takes a little bit of time to know, well, what's going on here. But at 4 years, these curves are the same. They're overlapping, as we see, one's crossing the other. And so at this point, there actually is not an overall survival benefit with the transplant, even although there are more deeper responses and the initial remissions are longer. I think that for many there is an expectation that ultimately the survival will be better with the transplant. However, one cannot decisively state that with 2 curves like this, which are actually overlapping. And so the recommendation is, as I showed you on my prior algorithm, the branching tree, where I think that now there needs to be a careful discussion about the pros and cons of the upfront transplant. I would say that a majority of myeloma experts would still favor the transplant. I think that we are definitely expecting that that will be a better outcome, but we are just waiting for these data to evolve to be able to make that decisive statement. It's kind of like the SWOG study. You know, I'm making some decisive statements 10 years later. Right now, with the transplant trial, we're like 4 years into it, and so we can't say just yet. So if we go to the next slide, which is slide number 14, and this was a late-breaking abstract. One of the key top abstracts at ASH 2016 was the ASH late-breaking abstract number LBA number 1, so it was the number 1 late-breaking abstract. And this was really, really interesting and key. A lot of people paying attention to this. And this was a large study of 758 patients. It was presented by Dr. Ed Stadmeyer, representing the ECOG or Alliance group, linked in with the bone marrow CTN group, a trial called the Stamina trial. Dr. Stadmeyer is based at UPenn, University of Pennsylvania in Philadelphia. And so he presented the results of this 3-arm study. And if you look at the top box in the middle, ACM, a third of the patient had an autologous stem cell transplant. They had C, which is consolidation, and then they had maintenance. So ACM, that was a third of the patients. TAM, a third of the patient had tandem transplants, so they had 2 transplants straight off the bat. And then the third group, AM, that means they just have autologous transplant and maintenance, no consolidation, and no second transplant. And I would say the big surprise that there was no difference between those 3 approaches. The tandem transplant was not better. If you look at the evaluation that was done at 38 months, PFS, which is the remission duration, the overall survival, the number of patients who had progressive disease, PD, is all the same. All those numbers are very, very close. And so I think I would say pretty much a big shock that we really did not see an advantage. There had been, and even at this year's ASH, there were other data, for example, from the Italian group indicating that double transplant had an advantage, particularly for high-risk patients, and that, you know, should still be strongly considered in that situation. However, in this study here, high-risk patients were included, and so I think that there are more data to be analyzed here. But for now, there is a feeling that double transplant across the board, it maybe is helpful for some set, maybe for the high-risk patients or higher-risk patients, but maybe not as much as we had been thinking. So this has really impacted a lot of people's approach. So moving to another topic, which is slide number 15, I think that within all of this, there is still this feeling that whatever the therapy, if it be VRD, a single transplant, or maybe a double transplant, in general, we're thinking that if there is a deeper response, if there's a complete remission, CR, then the outcome should be better, and it would be dictated by the status of the minimal residual disease. And so if you have a complete remission and the minimal residual disease is also negative, that would be your very best story. And what this is showing here on this series of graphs is that green box, the MRD negative patients, do the best. And so those are the patients who have a complete remission and are also MRD negative. But what the graph is also showing in the other graphs, the other colored graphs, is that if you are in a CR or PR or any of the other Rs, but you're not MRD negative, then you're pretty much the same and you're not as good. And so I think there is definitely an accumulation of data that it is whether or not that MRD is negative or not, which really makes the big difference in predicting how well is a patient going to do. And so if we go to the next slide, it really summarizes, which is the gist of a lot of abstracts that were presented at ASH by different groups from the US and from Europe, is that we need to integrate next generation MRD testing, which can be by immunophenotypic or by sequencing techniques. And so that is what's called NGF, which is next generation flow, which uses immunophenotypic, which is a immune method, or sequencing, which uses a molecular method, is that we need to integrate whichever one or both into our testing so that we can understand what is that MRD level, because that's really what we need to know in 2017 to know which treatment is working the best. And so the way that we would move forward with this is to start, for example, to look at maintenance. So slide number 17, which maintenance strategies are the best? And so if you look at patients who are in CR, it turns out that with these modern methods, like with NGF and NGS, which I'm going to talk about in just a second, about half of the patients would in fact be MRD positive, and half of them would be negative. And so this opens up a whole series of questions. So if you're MRD positive, what kind of a maintenance or new treatment should you use? And then how can we assess the outcomes for that? If you're MRD negative, is it okay to stop the treatment, or how do we handle these issues? And so this immediately opens up the story, which is that for MRD, it's great that we can test for it, but now it's just opened up a whole series of questions that we urgently need to answer. And so if we go to the next slide, it's got a bunch of charts with different colors on it, and that's to show you that, in fact, the immune method, or the next generation flow MRD method, monitoring method, this is in slide number 18, it identifies with 8 different colors all these different cells which are in the bone marrow. And it actually allows you to identify 15 different types of cells in the bone marrow. Now, among those cells, if you look at the box with just the red and the blue, which is the top of the 6 boxes on the right, you'll see that top left box there, it says clonal PCs, which are red, and normal PCs, which are in blue. So if you just look at the red and the blue, you can see, is there residual myeloma, which would be clonal PCs, or is it just normal PCs? So this is just one of the questions that you can ask and get answered. But if you look at the other boxes, there's a whole bunch of other things that you can look at. And you can look at the next box over, which has got a big maroon patch there. That maroon patch on the bottom left of that chart is where the red cell production is, and that is what we used to tell us that the sample is actually a bone marrow sample. If you don't have that maroon patch, then it tells us that there's no red cell production, that the sample is actually not bone marrow, there's not an adequate bone marrow sample, and so if you don't have any myeloma cells, that could be because there's no bone marrow there. And so it's a false sample. And then if you move to the other boxes, you can start to look at, well, what are the other immune cells? What are the B cells? What are the T cells? And you can use this to monitor the immune system, which is a key thing with daratumumab and some of the other emerging immune therapies. And so this is becoming a very powerful tool to assess MRD, but also to assess the immune status of the patient. We've also just completed a comparison of the flow and the sequencing methods on slide number 19. And key points are that, unfortunately, the NGS method doesn't work all the time, and so you can get results, what is shown here, 87% versus 100%, which is different. And then also that the new NGF method is actually a little bit more sensitive than the NGS method. We picked up 19 cases versus 13 cases, the p-value should actually be there's a missing 0 there. That should be 0.05, so that's obviously a significant difference. The NGS is a little bit more sensitive. And so what does it mean now if you are truly negative with this type of a more sensitive method? Well, what it means is that it really is starting to impact what we should expect. And so in slide number 20, you can see that it gives a progression-free survival, which at this point is basically a straight line out to 3 to 4 years. If you're truly negative at this sensitive level, less than 1 in a million, and it is an adequate bone marrow sample, then actually the patients are staying in remission for at least 3 to 4 years. And obviously, we're still expecting that there would be some relapse drop-off over time, but it really is starting to look like a really excellent predictor for long remissions. And as we move from 1 year to 3 years to 5 years, a subset of those patients will definitely be on the path to being cured. Now, what are the protocols that we can use to do that? Slide number 21 is just an example of a new protocol comparing 2 types of therapy, VMP versus KRD, then consolidation and maintenance. We just have to look at the role of maintenance in patients who are MRD positive and MRD negative. We just need to start to understand this. And so without spending a lot of time on the details of that, let me just go to the bottom line for this segment here, slide number 22, which is how should we be looking at MRD testing here in 2017? What are we really expecting? Well, certainly it's going to be in all the clinical trials. This is widely being tested now throughout the disease course, trying to see if we can achieve MRD negative, to study what are we going to do about MRD positive. Now, what about just the local hematologist, oncologist, sending the samples into these labs where increasingly they actually are able to do some of this more accurate testing? Well, I think that maybe it's still a little bit too soon because we still are not 100% sure what either a negative or a positive test means. However, as I say here, if the doctor is open and talks about this right from the outset so that the expectations are set, obviously if you have a CR and their MRD testing is negative, that's really good and is certainly better than if it's MRD positive, even although we might not be able to interpret it much beyond that at this time. So I think that careful review, discussion, and education are required even before such a test is drawn and sent off so that it's interpreted with care. So moving forward into the exciting area of where are we with relapse therapy and the new drugs. There is little doubt that the results with the daratumumab combination, so slide number 23, Pollux and Castor, which are the old images there that you see, the twins, the 2 studies, Pollux and Castor, daratumumab with Revlimid and Dex, which is the Pollux study, daratumumab with Velcade and Dex, that's the Castor study. So 2 3-drug combinations with daratumumab. And what do I mean by this? They are leading the way, game changers. Why am I saying that? Well, these are 2 trials that were conducted in early relapse disease, patients who had either 1 relapse or out to 3 relapses, and the results with those studies were probably the best that we have ever seen with a combination in this early relapse setting. And so really there is this use of the term game changer. And so if we go to the next slide, slide number 24, and a number of you, I think, have seen these data at least a couple of times in recent months. So if you look at early relapse and you look at lenalidomide-based studies, so this would be, in this case, daratumumab, the anti-CD20 CD38 monoclonal antibody, which comes from the Janssen company. And so if you look at that, that is the Pollux study. And so if you look at the Pollux study was the daratumumab Revdex versus the Revdex alone. So again, we're talking about a triplet versus a doublet. And if you look at the top red box that runs all the way across the top of the slide there, you'll see something which says 0.37, and this is something that's called a hazard ratio. And you would say, why in the world would I use this word, which sounds a bit crazy, to draw to your attention? Well, this is a statistical number where low is good. And so you'll see that that number is 3.7, and if you look at the other numbers to the right, you'll see that those are substantially higher, almost double, 6.9, 7.3, 7.4. And so what this means for statisticians and for myeloma investigators is that at the statistical level, this Pollux data, and this means that the Dara Revdex is significantly better than the Revdex. Now, the carfilzomib Revdex is better than Revdex. That's the Aspire trial. That's the next best to the right there, 0.69. But that's a big difference. And if you go over, you'll see that that number gets higher. And so this translates into what I put in the second red box, which is the complete response rate. And so patients who achieved at least a complete remission, 43%. Now, this is in a relapse trial with the combination of Dara Revdex, and you can see that that is versus 32%. So the Aspire trial, the carfilzomib, the Kyprolis Revdex, is in a similar ballpark, but you can see elotuzumab Revdex, 4%. I mean, it's not really even in the same ballpark. And then Ninlaro Revdex, which is the Tourmalins trial over on the right, 14%. Not even in the same ballpark. And so that's why I'm saying that these are results which really are making an important step forward. And if we go to the same with the Velcade combinations, the proteasome inhibitor, slide number 25, daratumumab with Velcade Dex, again, that crazy hazard ratio number is 0.39. You can see the other numbers are 5.3, 6.3, 72, obviously much higher, so low is good on that. And then you can see again in that complete remission box, 19% versus 13, 11, and 4. So again, this is showing an amazing added value of daratumumab, not just against its own comparator, but what has been experienced in the past with other combos. And so, again, looking at these different algorithms, how does that translate into what we would suggest for a patient in 2017? If a patient is in that early relapse in 2017, well, the MSMART guidelines have picked up on this, and they're saying, well, in our opinion, if you're not refractory to Revlimid, then you should probably have a Revlimid Dex combo with Dara. If you have kind of run out of Revlimid, then probably your best choice is to try the daratumumab plus Velcade index, or maybe the Cybor-D. And so this has really moved into like the frontline category in terms of what would be your options for that relapse. And then it's influenced or moved down some of the other choices. If you go to slide number 27, after that, you could switch to your Cybor-D, some of the other combinations, ixazomib, Ninlaro, elotuzumab, panobinostat, and so those have been kind of delegated to alternate options later, although obviously if the daratumumab was not available, and this unfortunately is the case in many places around the world, some of those other choices would certainly what is being used. Another thing to consider is slide number 28, burden on the healthcare system, and I think that everyone is a little bit concerned about that because for the patient, it has an impact in terms of how often do you need to come into the clinic, and then also what is the total cost of all of this. And so you'll see that I've compared here, and this is something that was done by Philippe Moreau at our satellite session at ASH this year, which was a very, very well-attended session, over 1,000 people there, and I think most people really liked this particular session because we got into some of these details, and he compared, okay, if you look at ixazomib Revdex, carfilzomib Revdex, elotuzumab Revdex, and dararebdex, what are the implications for the patient? Well, ixazomib is by mouth, so for 18 months, the patient needs to come in 18 times. They come in once a month, get checked. However, if you have carfilzomib, that's given twice a week IV. That means you've got to come in 96 times. So this is really an important difference. And then the infusion is over 2 hours and 130 minutes. So, and in addition, you'll see under that there may also be a need for extra IV fluids. Then if you look at elotuzumab, that's somewhere in between, and then you'll see that daratumumab, 28 visits, so it's really, I would say, a little bit more manageable, and what was presented at ASH is that now we're looking at giving the DARA by sub-Q versus IV, and so there's an awareness that we need to be looking at this burden on the healthcare system, and so I think that the DARA stacks up, or will potentially stack up quite well in this regard. We do have advantages. The ixazomib in different combos, people are definitely looking at that. That once a month visit is really very attractive. So, slide 29. As we move to the end of this segment, how do you prioritize these choices? Obviously, the efficacy, the hazard ratio, the toxicity, the ease of administration, costs and reimbursement, which can vary a lot depending on your coverage plan. But ultimately, we should not move much away from picking the treatment, if we can, that will give you the maximum response. And so the exciting new area, which I'm going to finish up with here, is what new therapies did we hear about at ASH? And when I talked about these before, we were not sure what would be the reaction of the various investigators when they heard these updated presentations. And so what I can do now is give you that feedback that happened when these abstracts were presented at ASH. And so slide number 30, this was really quite exciting, and I touched on it before ASH, giving an AIDS drug. This AIDS drug is called nalfinavir. This is a standard drug for the treatment of AIDS. So this is an antivirus agent. And so this group from Switzerland, St. Gallen in Switzerland, they treated 34 patients because they had some data in the lab that this could overcome resistance to Velcade. And indeed, it did seem to do that in these 34 patients. They had an overall response rate, PR or better, 65%. Many investigators had questions about this. They said, well, and this was presented for open discussion at our IMWG breakfast, where there was a lot of chance for questions. And the investigator said, well, are you sure these patients were resistant to Velcade? And he said, yes, they were. And, how long did you give this? All kinds of different questions about this particular therapy. And I think the bottom line is that mostly people were pretty convinced that this was really overcoming Velcade resistance. However, as would be normal, everyone said, okay, well, we're going to check that out. And so I would have to say I have not heard yet of the starting of trials in the U.S. and elsewhere, but I think very soon we're going to be seeing a number of studies in the U.S. and Europe checking out this combination because it's pretty well tolerated, and if this is true, this is a very interesting and important new observation that we have not been expecting. Slide number 31 is part of what convinced people that this means something. You can see that I've outlined here VGPR and PR, so you can see a substantial number of these 34 patients had deep dropping of the myeloma protein level. 90% drop VGPR. You can see there were 5 patients there right there with VGPR. So this depth of response, the percentage of responding patients, and the fact that the Swiss investigator did seem to be pretty careful about the fact that the patients were resistant to Velcade before. So exciting new information. Next slide, 32, venetoclax. This is something that inhibits BCL2, which is something that allows myeloma cells to survive. It's a protein that keeps the cells from being destroyed. And if you block that, then the cells will actually go ahead and be destroyed. So a very important drug, which works best in patients who have, for some reason, a lot of BCL2 in the myeloma cells. And this turns out to be the case in patients who have the translocation 1114. So T1114. These patients are particularly susceptible to this therapy, and in fact, in the study of 66 patients presented by Shaji Kumar, 40% of those patients responded, including patients with deep responses, stringent CR, VGPRs. You can see that orange box there and above. So very important responses, and I think people are pretty convinced about that. And I think this will be moving ahead, possibly with an idea for approval, certainly for patients with this T1114. And then if we go to the next slide, people were also pretty impressed by the presentation by Philippe Moreau, where he gave this venetoclax along with bortezomib and dex, Velcade and dex, in the relapse refractory setting. And the most important box here, strangely enough, these studies both had 66 patients. I don't know how they came up with that. But off to the right, you'll see that in this relapse refractory setting, overall response rate, 94% with this combo in patients who are not fully refractory to the Velcade. So I think there's a lot of hope that even in patients who may not have this T1114, this could be a broadly active drug in combo, and people were talking about now to create an oral combination, which would be venetoclax, Ninlaro, and dex. And so you can look out for a trial of that starting probably rather soon, as a matter of fact. If we go to the next slide, as I'm moving towards the close of what I'm going to say today, a lot of interest in this drug called selinexor. In this case, the EX refers to export, and so the selinexor is something that is a completely new mechanism of action. It blocks the export of anti-oncogenes, and so an example of an anti-oncogene would be P53. So P53 is a protein which is protective, and so if you lose P53, then that can make the cells more malignant and to grow. And so whatever amount of P53 is being produced, the selinexor retains it in the nucleus of the cell, and so this is something that is very important. So the therapy is new, and it was studied by Dan Vogel and the group. There's a cooperative group study here sponsored by Karyopharm in patients with refractory disease. 48 patients were refractory. 31 are in this category, which is called penta-refractory. That means that they've refractory to 5 different regimens, including daratumumab. And so this qualifies as to what is currently considered an unmet need. And so it's expected that this can be important to allow selinexor to possibly be eligible for approval in this relapse refractory setting. And so there is an expanded trial upcoming in 2017 with the idea to submit those data to the FDA in the hopes of getting an FDA approval for selinexor. So I think from the patient standpoint, this penta-refractory situation or even quad-refractory, if you go to the next slide, there are a number of trials upcoming. So we have selinexor, which is with Dex, which is the STORM trial I just showed you, selinexor with Velcade Dex, and there's also selinexor with pomalidomide Dex and carfilzomib Dex. The combinations are also showing some pretty good results. So on slide 35, you can see patients who are refractory, selinexor, Velcade Dex, a 58% response rate right there. So you can see that there is hope that selinexor Dex is working at that 21, 22% level, and in these other combinations, maybe a bit higher. So just watch out for that. Those are certainly options to consider for a patient who may be in that refractory situation. And then a final area I just want to touch on with an example, slide 36, anti-CD19 CAR T cells. So these are immune T cells which are harvested from the patient and then engineered to attack different targets, in this case CD19, which is on the surface of about 5% of patients with myeloma. And so there are a limited number of patients who've been treated. In this case, 10 patients were presented by Dr. Adam Cohen from University of Pennsylvania. And the key point is that this is certainly not a universally beneficial therapy. It's given in combination with autologous stem cell transplant, so it's not so clear how much is coming from the T cells, how much is coming from the transplant. Some patients, 3 patients, had long VGPRs, but certainly not every patient. And there are some concerns about this type of therapy with something called cytokine storm. This type of activated T cell, when you give it to a patient, can really, really stir up the immune system and can cause even some brain problems. And one of the studies linked to this by the company Juno, the study was actually shut down because 2 patients actually died because of this. So this is absolutely not a trivial therapy, although it may have powerful anti-myeloma effects. There are a number of variations on that. If you go to the next slide summarizing all of this, in the middle of that you can see CAR T CD19, but also BCMA, B-cell maturation antibody. This is another target. You can make the T cells attack BCMA, and this may be a better target. But again, I think it's going to take some time to see how effective this is, but certainly in my mind, how safe is this? And so if we look at slide number 37, using that AIDS drug, NFV, very exciting. I'm really interested to see if this can be validated, and this could be a simple added approach which could be very, very helpful, possibly for many patients. The venetoclax, the BCL2 inhibitor, T1114 for sure, it's helpful. Selinexor, available especially in the refractory setting. What we didn't get much about at ASH was the checkpoint inhibitors. We're waiting to see. Those are used in combination. Those block the immune system also. They don't work alone in myeloma, but they do work well in combination with Revlimid and pomalidomide, and we did have some updated data on that, but we'd had that before as well. And then not too much about virotherapy at the recent ASH. This is using the measles vaccine approach and things related to that. That's been in kind of a waiting period right now. The studies have been ongoing, and so I think that at the next ASH, we maybe will get some updates as to, well, where are we with this virotherapy, measles, HSV virus therapy approach to see how that might work out. And so just in closing, before we start with the questions, what are the most exciting and new evolving therapies? Well, I've given you my thoughts, but I think what's most important now is for you to have this chance to let me know, well, what should we talk about? What are the questions that you have? Certainly, very, very active discussions at ASH this year, a lot of ideas frontline, and certainly a lot of new ideas about what will be the next new wave of therapies that we should be looking for. So I look forward to any questions or discussion points that you might have. Thank you. And thanks to our sponsors again on that last slide 39, as Susie mentioned. So please dial in, let us know if you've got any questions here.
Your first question comes from Jenny Hack.
All right. Hi, Jenny.
Hi, Doctor. I want to thank you for such a wonderful presentation. I really appreciate it.
Okay, well, thank you.
And I was wondering if there was anything discussion on deletion 17p.
Yes, well, I touched on it a little bit with the selinexor. That there's even this idea that since it's focused on the 17p, that selinexor, especially in the combinations, might be particularly helpful in that 17p situation, okay?
Okay.
But there's also the hope that the immune therapies, which are looking at the surface of the cell, will also be helpful in the 17p deletion patients. So maybe the checkpoint inhibitors and the CAR T cell type therapies, they would attack the myeloma independent of the 17p. But I think basically we are waiting for what is the recommended approach in that 17p situation. So we're kind of looking at a number of the new agents, a number of the new combos. But there are certainly a few to consider and recommend, okay?
Okay, I appreciate it. Is it the Mill study, is that similar to the CAR T cell?
What was that word?
The Mill study?
Mill. I'm not sure. There are a number of these immune studies, so that there's the CAR T. There's a number of them that you'll probably see posted. There's the CAR T CD19, where only a few patients are actually CD19 positive. But there's a number of studies with the CAR T BCMA, this B cell maturation antibody. There was also a monoclonal antibody against this BCMA that was also presented by Adam Cohen. So there's a quite interesting study with the monoclonal antibody against BCMA. And then there are these checkpoint inhibitor studies. Quite a few of those immune studies. So that if you go to, if you call the hotline, or if you go, certainly the hotline will be glad to guide you towards studies that are open near you.
Okay, I really appreciate it. Thank you, Doctor.
All right.
The next question comes from Karen Nichols.
Hi, Karen.
Yes. Hello, Dr. Durie. I am concerned, and I keep asking this question. For those of us who did not have the opportunity to have MRD testing when we were first diagnosed, for example, I was diagnosed in 2010, what is there available for us now for a follow-up?
Right. Well, the good news is that, MRD testing could certainly be done now. I mean, the MRD testing, the crazy thing about that is that you do it actually later when you've had your maximum response to see if there's any disease left. And so we can look at the myeloma up front to see the pattern of the myeloma, but the key testing for the MRD is when you have gone through your front line, possibly you've had your transplant or maybe a year of maintenance, to see is there any myeloma left, is there MRD negative, let's say at the 1 or 2 year time point or even later. And so one advantage of the NGF, the flow cytometry test, is that it could be done at any time, and this year is a key year for the NGF because it's going to be available across this country at a number of centers. Already the Mayo Clinic is set up as kind of a reference lab, but at Roswell Park, at a couple of centers in New York, in South Carolina, a number of the centers are just in the final stages of getting set up to make this available in a way that would be accessible across the country, so that if you talk to your doctor about it, and if you're otherwise in a good response, as I said, with proper discussion, this could be quite probably done for you if you want it. Okay.
Okay. Thank you very much.
Okay.
And your next question is from Kim, Rochester.
Yes, thank you, Doctor, for this excellent conference. My question is, in these studies you documented, do you consider pomalidomide interchangeable with Revlimid pretty much? I mean, do you expect the same kind of responses to them?
Okay, so it's interesting. We haven't really been talking a whole lot about pomalidomide this last year or two, but I actually think that pomalidomide is a very, very important drug, and it's basically the backup after Revlimid. In other words, once you kind of run out of Revlimid and the myeloma is active again, pomalidomide is very important in that backup situation. And so many times if you've had a good response to Revlimid in the past, pomalidomide as that next generation of IMiD can do an excellent job, and you can have a sustained remission. A number of you on the phone may be aware of the marathon runner who has been... Don Wright, I'm being reminded here, Don Wright, who has been explaining that he's been on pomalidomide now for about 7 years after being previously on Revlimid and a bunch of other therapies, and he's run a marathon in every state in the U.S. so I think that it's certainly not a drug to be ignored, and certainly by itself as like a PomDex or pomalidomide carfilzomib dex or pomalidomide Velcade dex, these combinations are actually quite powerful in that middle to late relapse setting. And obviously pomalidomide is by mouth, tends to be quite well tolerated, and so it's certainly a drug that I quite like to use, and many patients are very happy on that with and tolerate it well. Okay?
Yeah.
Okay.
And the next question is from Bill Brewster.
All right. Hi, Bill.
Yes. Hello, Doctor. Thank you very much. My M spike is 0, undetectable, after my second stem cell transplant, but I had a clonal sequence test that shows 13 per million. How close, considering MRD, is that?
Pretty close. I mean, it's obviously, but I guess it's close, but no cigar. I mean, it's very close. But the main thing that I would emphasize to you is one of the things that I mentioned as part of my presentation is that is a very, very low level. What we don't know right now is if we look at the long term, if you've got 13 out of a million, how different is that than 0 out of a million? And what we're learning is that there are some patients who are at a very low level that can do great for many years. We have a separate study that we're doing, which is called our long survival study, where we're looking at patients who've been out 10 years and even 20 years. And what we're discovering is that although some of those patients are definitely MRD negative using the sequencing method, we're using the sequencing to study this, some of those patients do have like 13 out of a million cells there, and they're doing fine 10 and 20 years later. And so we're trying to understand the subset of patients. It's at least 10, 15, maybe 20% of the patients where they can do well with these kind of low levels of disease for many years. And so through our Black Swan, we have a project to see, is there anything different about these 13 cells to say, okay, well, maybe these are like a little bit more benign cells, maybe this is kind of like an MGUS that you've gone back to, or, maybe not. And so there's a lot to be learned about it, but it could be absolutely fine. So I wouldn't rush to be doing anything different, okay?
Okay, well, I'm high risk. And
that does make a difference, obviously.
And what I'm doing is I'm trying Ninlero as a consolidation therapy and maintenance therapy.
Okay, well, I would certainly be supportive of that. And so this kind of tells you that actually you need, several bits of information to make the proper decision. And so that MRD test is just one piece of information, but, that high-risk information tells me, well, could be smart to use some ongoing therapy, yes.
Okay, well, thank you very much.
Okay. Thank you.
Okay. Bye.
The next question is from Charles Shanley.
Good evening, Charles.
Good evening, Doctor. If one is intolerant of Revlimid, lenalidomide, are they more likely to be intolerant of also pomalidomide? In other words, are all IMiDs the same?
These are kind of independent. I mean, sometimes there can be a linkage, especially if there's been a really bad reaction, like a skin reaction or something, that there would be a concern. But many times, patients who've had trouble with Revlimid can handle pomalidomide just fine. And so it's a little bit complicated to get into. In terms of sequencing the drugs, sometimes if we've used like an IMiD, like Revlimid, depending on the situation, we might suggest switching to a proteasome inhibitor like a Velcade or carfilzomib or even an Enlaro, so that we kind of mix it up a little bit in terms of the therapy. But certainly, pomalidomide could certainly be tried and might be tolerated just fine.
Thank you, Doctor.
Yeah. It could
I have dozens of questions, but I'll hit you up in Boca.
Okay, well, I'll be looking out for that when we're down there coming up soon, okay?
And the next question is from Gary Precer.
All right.
Okay, hi. After a failed stem cell, I'm being maintained on ERD. And I've had asymptomatic myeloma that was discovered incidentally. All my symptoms are from the treatment. And the worst symptoms come from the bisphosphonate that I'm told really may extend overall life expectancy. And nowhere in any of the studies is bisphosphonate alluded to.
Right. Okay. Well, happy to try to help you with these points here. So, when you say ERD, I'm assuming that might be elotuzumab. So
yes.
I'm just clarifying that for other people who are listening. So you're using, it's a little bit unusual, the elotuzumab RD, but that's certainly an option.
Yeah, that's it.
Now, the thing about the bisphosphonates, however, is that there is a large study that came out of the UK that said that patients taking Zometa had some improvement in survival versus an older type of bisphosphonate. But I think that it's still a little bit unclear how much added survival benefit you get with coming in from the bisphosphonate. But it's certainly reasonable to consider. Bisphosphonates are not all tolerated the same, and so the first thing to do would be to try switching from one to another. So we have Zometa and Iridia. So this would be maybe with Zometa, is that right?
Yeah, the Zometa put me in the hospital overnight. The Iridia I can tolerate. I had a miserable week of diarrhea and stomach pains and flu symptoms. And
so the Iridia that you can handle it, you think? Or
poorly. Do we assume that everybody in all these studies is on a bisphosphonate, or?
Many of them are, yes. So I would say a majority, at least 70% of the patients, 80% of these patients in these different studies are on a bisphosphonate for at least 1 to 3 years, I would say, yes. So you can assume that. And so it makes it a little bit hard to break out that survival benefit because most of the patients day to day in practice are actually taking or being given the bisphosphonates. But the key thing for you is that you can switch from one to the other and you may tolerate just fine. Okay?
But that's interesting that so many of the patients are on it, but it's never mentioned. Okay, that helps.
Yes. Okay, but now they're aware more. Okay, thanks for your question.
Thank you.
So we have time for one more question.
All right, one more question. All right. So, no problems.
And the last question is from Betty Hoffman.
All right. Hi, Betty.
Hi, thank you. Hi, how you doing?
Just fine, thank you.
Good, and thank you so much as always. This is kind of a two-part question. The first is with Dara, and I can't say the whole name properly, so I'll use the nickname. What are the side effects? Nobody has talked about that.
Okay, well, I think broadly it would be good to say and correct to say that it's pretty well tolerated. However, there is an issue with the first infusion, and so It is given IV, and with the first infusion, there's definitely a risk of allergic reactions with that first infusion. And so that is the main thing to be alert for. And so when DARA is getting started, a lot of caution with that first dose. There's a hope that by switching from IV to sub-Q, to the subcutaneous injection, we'll be able to get away from that reaction because of the IV. But that's the most important thing. Now, beyond that, besides the inconvenience of coming in from the shot, it's mostly fairly well tolerated. We do see some reduction in blood counts. We do some fatigue and some other things, but I would say broadly is rather well tolerated. Okay.
And my second question regarding DARA or any of the immunotherapy drugs is, can they be or are they effective for people who've had autoimmune diseases?
Yes, although possibly with some caution. I would say particularly there have been some questions related to the checkpoint inhibitors in that setting. But certainly daratumumab can be used in that setting. As you may be aware, some patients with myeloma do have a background of immune problems, even some kind of an immune disease, and so yes, it can be definitely used in that setting. That would be And then the final point.
When you have an autoimmune disease, is it that your immune system is working too much, too little, or on the wrong thing?
Right. Well, you've summarized the three possibilities there, and it can be, like all of the above. I mean, sometimes the immune system can be overactive. You can have like producing antibodies against something, or you could have like an immune deficiency, or it's just dysfunctional. And so, the thing about myeloma is, as a disease, it emerges in a setting in which the immune system is not 100%, where it could be abnormal in some fashion. And so we should not allow that to stop us from thinking about an immune therapy. And so there are different kinds of immune dysfunction, but still we should be open to something like DARA or some of the other immune therapies, although I would be a little bit more cautious, as I say, with the checkpoint inhibitors in that setting, okay?
Yes. Thank you so much.
Okay, well, I think that we're going to stop at this point, and so thank you for being so active with the questions, and we certainly appreciate the interest. And any follow-up points, you can certainly get in touch. So, Susie.
Well, Brian, thank you, Brian. I'm sure everyone on the call tonight really appreciated the update. And it's clear that people have a lot of questions, so don't forget to call our info line. They'll be able to help you. And that toll-free number is 800-452-2873. And another fantastic way to stay abreast of all the new data and how it impacts your treatment is to attend one of our patient seminars. The first one of the year will be in Boca Raton, Florida, on March 17th and 18th, and you can register. Just call the IMF, and I'm sure you'll be glad that you did. Again, our number is 800-452-2873. We'll also be holding patient seminars in the following cities: Short Hills, New Jersey, April 7th and 8th, Los Angeles, August 18th and 19th, and Dallas, October 6th and 7th. And my colleague Kelly Cox will also be holding 12 regional community workshops across the country. And so you can just, again, call us and talk to Kelly, and he'll tell you where those will be. Again, thanks so much to our wonderful sponsors, Amgen, Celgene, Janssen, and Takeda Oncology. And I also want to thank our wonderful support group team here at the IMF, Robin, Kelly, Nancy, Sue, and Ann, who work with groups across the country and helping you in so many positive ways. So that's it. I'm going to go home, feed my dogs, and make dinner. So thank you all very, very much, and we hope to see you soon. Take care.
Thank you all. Have a great evening.